Thank you so much for that. Now I'll pass it on to you, Tony, to lead the discussion.
Hello.
There you are.
Hi. Yes, I'm here. Thank you. Look, thanks Maria, and thanks for those fantastic presentations, which cover a lot of ground in terms of how data and big data in particular is being used, and a lot of the issues around that going forward. So there's a lot of, I think, important issues to discuss, thinking about what people have said. So I'd like to, we've got a few questions in the chat, and I've got a few things to kind of raise with the panel as well. I guess there's a couple of questions for you, Christian, to begin with. First, I guess, what are the criteria by which you assess whether patients in the GLAD program are no longer benefiting from the non-operative management and need to see a surgeon?
Yeah, it's a good question, and it's not a black and white answer. I think the really important thing is it's a shared decision-making process. So I think having a conversation with the patient about some key criteria that are likely to indicate someone would benefit from a joint replacement surgery. So that's the first thing, and appropriately try non-surgical care first is part of that. But the other considerations we need to have is the severity of their joint disease, and some of the great work from the Opus group around this highlights this. So if their radiographic severity is not there, then the joint replacement is not likely to help them. And then it probably builds into some of the other criteria around, look, if they've appropriately tried what we do with GLAD, which is quality education and exercise, but there's psychological factors there that are driving their pain and disability. Certainly the SMART tool that Opus Group have been working on highlights this, then that's something they should be going off and exploring as well. And of course, GLAD doesn't focus on diet and weight loss. It certainly covers it and opens the conversation. But if someone is obese and they're still not happy with where they're at, then that needs to be a conversation, and that should be somewhere they should be steered to, is to get that support for weight loss. How we actually achieve that's a whole other question. And ultimately, we need to have that conversation, and then, if required, then facilitate the person to still see the surgeon. So it's not a black and white answer, but I think, and it might be that at the end of the 3-month point, you reset some goals of what they want to do. And the great thing about exercise is you can keep progressing it. So you can take someone from being happier with their life and they're back to doing the things they like. And they say, actually, now I want to run. You say, okay, that's great. We can try and work you back towards running, but it's going to take another 3 or 6 months of building up your strength and muscle power and capacity. And so continuing to work on those goals. So the journey's not over. And equally, someone might say, I'm happy with where I'm at now. I just want to stay there. And so you set a plan for them to continue to exercise. And if they regress 3 months later or 6 months later or 2 or 3 years later, that doesn't mean they have to jump to joint replacement. They might revisit some of the education points in the exercise. So it's a conversation that's ongoing. And I think it doesn't hurt to get a surgical opinion from a surgeon who has really good knowledge of non-surgical care and surgical care to have that conversation with them as well. And it's not not black and white. Hopefully that answers the question a little bit.
Yeah, no, thanks. I guess there's another question about GLAD. So if I went to a GP and wanted him or her to do something about my joint pain, how does that GP know about GLAD? How do they get to know about it?
Yeah, it's a great question. So most of it's been word of mouth at the moment. It's a not-for-profit initiative. We started with nothing. We sort of ground up process, and so we've worked really hard to try and support physiotherapists to go and promote the program in their local setting. So one of the advantages of having private practices deliver the program is they're incentivized because they'll earn money by delivering the program. So of course, if they can get GPs to refer, then that'll happen. So we've set them up with different resources to educate GPs about it. So that's important. We're trying to work in with the PHNs at the moment to get education out. The problem is we have 32 of them across the country, I think, and so they don't talk to each other very well. So we've made some good inroads into a couple of the Melbourne ones, and we've got some information now up on a platform called Health Pathways, which a lot of them use. And so there's information there, which is great. We would love to embed it in things like Handy, try to start some of those conversations at the moment. Once the GP does know about it and the patient does know about it, there's a website set up where you can go on there and you can search where the locations are. So so there's now over 400 in Australia. The limiting factor to that is the patient who maybe doesn't have the means to pay for it. It's really difficult to navigate and identify where they could access the program for free or at low cost. There's probably a lot of availability in metropolitan Melbourne. A lot of community health centres offer the program, so that's great. But there's some pockets where that doesn't happen. And so it's a little bit of hit and miss as to whether you can get easily available access to the program just because of our health system funding model at the moment.
Yeah.
But GPs, if they were interested in it, certainly use the website to find locations for the patient. And then unfortunately, the navigation from there can be quite challenging.
Yeah. And just one more question on GLAD, and then we'll move on. What's your biggest difficulty in implementing GLAD? Is it about that kind of getting it known and out there? Was it about training the providers? Or?
So if you go to different levels, health system is the biggest challenge because it's not adequately funded in both public and private settings. And there's different reasons for that. So that's the biggest one. And then from us as a research team, our biggest challenge is probably the training and ensuring the program continues to be delivered with high fidelity. So we spend a lot of our time supporting the clinics to deliver it appropriately, and also making sure that they do deliver it appropriately. So we occasionally would get a complaint from a patient who says, hey, this wasn't what GLAD was meant to be. And then we're following up with clinics and they've reduced their exercise times, for example, because the private health insurers will only pay them a certain amount of money for a group exercise session. So they say, well, we can only offer 30 minutes. And then they don't give the group education sessions because they don't get paid to do it. So they cut that out. So it comes back to that health system funding. So health system funding makes it harder for us to manage the clinician level as well.
Yeah. Okay. I guess one of the things that Opus was intended to do is to look at this patient journey from referral right through to other options, including surgery and treatment. And behind that, I guess there's a whole issue about the data that we use, which Opus has been following up and following through. And we've heard lots of examples about how that's progressing and what people are doing and what research they're doing. But it also suggests that, it raises issues for me as a researcher about access to data to do research. But then there's also lots of issues to clinicians about how they kind of use data to aid their decision-making, whether that be predictive tools or artificial intelligence to help them make decisions. And I just want to ask Stephen, first of all, data linkage access to data seems to be getting better. And we've all had experiences as researchers of trying to access data for research. Should we continuing to be optimistic, Stephen?
Well, Tony, it's always going to be a challenge because you've got the balancing interests of individual privacy and collective good through improvements driven by research. And that balance can shift over time. I think the very fact that it is now possible to do linkage and that there are linkage centres established and that the Australian Bureau of Statistics has established a linkage program called the Multi-Agency Data Integration Project, MADIP, all point to the fact that governments/bureaucrats recognise the importance of this, of linkage, and the power of it. And so I'm an optimist, but always recognising that there can be slips backwards. So we have to be careful. And we, as researchers, have to be careful that we are respecting the interests of the people who have contributed the data, many of whom didn't know that they contributed it.
Yeah. And I think, and also you raised, I guess there's a number of uses of big data and how this is used. And one of them is to describe stuff like, so what's the problem, and can it be used to highlight some new issue or some new association, and also a lot of stuff about predictive analytics. And and again, and I guess that side of it is going to be more useful to clinicians. But there's also the issue of, well, okay, you identified a problem, what can we do about it? And that does require, I guess, you know, a conceptual framework, a theory about what's going on in order to interpret the data, to try and make sense of it. And that again requires a lot more skills, I think, than we currently have. I wondered if anybody just wanted to reflect on their experience with the skill set that's required. I mean, obviously in Opus we've got some great smart people looking at these data sets that we have and trying to make sense of them. But in terms of training those kinds of people who aren't necessarily clinicians as well, you know, I mean, Michelle, what do you think is the kind of issues around capacity building around these data sets that we're getting access to? Because they are very complex, take a lot of effort and a lot of skill. And I always find that sometimes it's very hard to find those skills.
It is challenging to find the skills, but I think it's because it's challenging to get funding for these types of initiatives. So if you had funding for the initiatives, that's been one of our biggest challenges, although ours comparatively might not be considered big data. It is in-depth data though, and trying to fund a registry, I have felt, well, we haven't been able to fund it. And then so with the funding would come the opportunity to actually capacity build and train people up. I'd be interested to know, Maria, your experience with this and how you went about getting funding for the ROSA registry and then building capacity.
Sure. Actually, that was one of the questions, Tony, that I was going to ask too. But in our experience with the Registry of Senior Australians, we had infrastructure funding from the state government, and by an act of God, we've also received funding from the Medical Research Future Fund now for infrastructure, which nobody's ever gotten before. So, but what I am trying to do is aim towards making the registry sustainable 3 years from now, with Commonwealth support through the Department of Health, through the National Clinical Quality Registries Initiative. So they have released a new framework and highlighted areas of substantial need. And I'm hoping that that's where we'll fit in. But that doesn't cover the capacity building that you're talking about, which is the skills and the programmers, the computer scientists, you know, the high-level epidemiologists. That the only way I found so far is to fund through projects and project grants. And it's, yeah, so that's, I was curious what your institute, Stephen, does in order to support that, you know, that level of analysis. Where do you get your support and how do you train the people that you have working on your data?
So the Grattan Institute is funded by an endowment. So we got funding from the Commonwealth and state governments, DHT and NAB Bank, to contribute to public policy in the country. We're very small. So the health team is normally 3.4 staff, including myself. And so we're a very, very small team. At the moment, we're down one because we're between hires, but and basically it's all on the job training. So for all of the analysis is, with the exception of the South Australian, the Royal Adelaide Hospital staff, is all done in-house by people who are self-taught. We have very, 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 very good junior staff.
I was going to say you're very, very productive, and that's really incredible. You have very productive staff. So
I think we've been fortunate as well because we have our group of PhD students working on the smart data, but it would be great to have something beyond that, because it is, you know, they will move on and develop their careers in other areas. But I don't know, I honestly don't have the answer to how you capacity build when you can't secure funding. At the moment, most of our funding like you said, Maria, comes through our project grants. And even then, we don't necessarily formally fund the Smart Registry through project grants, but we build in a moiety for data collection and so forth. So that's how we cobble it all together.
Mm-hmm.
I have one more question though, Michelle, if you don't mind, about the findings from the registry and more about how the data is used these days. You talked a lot about the impact that it's had in, you know, guidelines and other products, but within the community of surgeons that contribute data to the Smart Registry, what changes in practice have you seen? I'm sure there has been quite a few changes as you are producing so much information over the last 20 years now. What are some of the major things you've observed?
Well, I think that change is slow. Changing practices, you know, takes a lot of time and takes a lot of data. And we were actually finding that we didn't have a sense that just feeding back to surgeons, you know, producing papers and publications was actually having an impact on changing practice, which is why we actually developed the nomogram. And we actually did some qualitative research around, I guess, what would motivate surgeons to change practice. And for clinicians, the feedback we got was they really want to, although they understand that there's a cohort of people who don't do so well from surgery, they wanted to know what was their own outcomes, what are their own results, and they would need to see that in order to be able to consider changing their decision-making practices, which is why we developed the Smart Knee tool. And so it'll take time, but to see whether that actually had, what sort of level of impact that has on changing practice. I do think we see people being, surgeons being more discerning around patients who've got, you know, extreme obesity. They are looking, since we've introduced the Smart Knee tool, I do get calls from surgeons saying, well, how do I access alternative treatments for my patients? So I think there's that next level that we need to go to make it straightforward and streamlined for surgeons to actually opt into these other areas of treatment.
Because I mean, I guess it seems to be that the demand for capacity for this kind of stuff through the demand for clinicians for this kind of information is quite important, and often, you know, the stage from creating a data asset to actually getting it used, getting information like that, and then implementing it and trying to change clinicians' behavior is a whole other ball game. But I guess that's where the demand would be clinically to kind of, you know, get funding to kind of try and fund the back end of this as well. But yeah, there's just a couple of other questions in the chat just to go through. One is, I guess, how do we think Australia's data linkage capabilities, access to linked data, compares internationally? And I mean, I broadly think that it's quite patchy. I mean, if you live in Scandinavia, you've got everything linked to everything. And other countries kind of have different linkage systems depending on the way health services are organised as well, I guess. Would that be the view of others on the panel?
I certainly have been over to Europe and had a look at their data linkage systems, and they're far more advanced than what we have in Australia, I think. There's just an acceptance amongst society that data will be collected and linked. It just seems to hum along in the background. There's not an over-awareness of it. It's just happening. And they have institutes where they house registries, and the registries actually link together. It's a wonderful thing. Internationally, though, I don't think there's a lot of linkage that occurs across countries because of data privacy, and it's very involved to do. So there's more sort of separate comparative work done, but I've not been able to successfully link data across countries before.
Yeah.
So I spent some time at the Manitoba Centre for Health Policy in Canada some years ago, and they started small as linking hospital data, medical data, pharmaceutical data, and then the death data and the demographic data. And they slowly expanded their collection of health data, all linked for Manitoba. Now, Manitoba's only a population of 1.5 million or so. But then they started getting the prisons data, the schools data, the social welfare data, and they built this amazing multi-sector linked data set that you can do amazing stuff that we could only ever dream of. And they did it, as I said, starting small, but in a small country, they have the networks and funded by the government. They have to actually provide benefits, but then they can use the data and others can use the data for linked data exercises. And they have shown over decades the power of the linked data. And I think that's part of what we have to do to show that it does return a benefit back to the community.
That kind of reminds me a little bit, I think, of the New Zealand model as well. I don't know how that was built, but they actually have linked quite extensively. And I wonder if, to some extent, the success of that is actually, as you say, Stephen, it's a smallish country, and it's government funded. And over in Europe, data collection for registries is government funded as well. So I think that contributes to success.
Christian, I wondered, as a clinician, I guess, how you view the linked big data space in terms of how things could be useful to you. I mean, you're obviously collecting your own data through GLAD, and you'll be using that in various ways. But I mean, what would you like to see as a clinician at your fingertips to help you?
Yeah, I think so. Peter popped a question in the Q&A function as well about identifying people who don't do well with something. And I think that's a really important question. We often look at data and say who does well with something, but certainly within physio practice, most people respond reasonably well. It's identifying those who don't do well. So they're the types of questions we want to answer. And I guess just to speak to Peter's question, we now have a data asset that we can start to look at, but we have the same problems that have been discussed, is the capacity to do that. And it's taken us some time to build some capacity, and we're hoping to look at that a little bit more in the next year or two. If someone gave us some money to do it, we could do it very quickly and give the answer to the clinicians about who won't respond to the program. But without that funding, we'll get it done, but it'll take us a little bit of time to do it.
Yeah. No, that's good. Okay. I guess, we've got a couple of minutes left, but just to kind of talk a bit more about, and unfortunately, Ross couldn't stay with us in this panel, but her question on AI about whether the computer knows best or not, I thought that was quite an interesting issue. And I guess, I mean, don't know much about this, but certainly in areas such as radiology and diagnostics, there's evidence to show that the computer might know best. And I wondered, what are the issues around that when clinicians are beginning to try to use AI and which is backed by all of this data to try and help them make the decisions, because it kind of can put clinicians out of a job, right?
If I speak to that, putting my clinician hat on, I think one of the biggest struggles is, as a clinician, you're typically treating people with pain and disability, and pain and disability is influenced by so many different factors that are really challenging, if not impossible, to measure. So you go back to what's going to influence an outcome of someone who might not respond. A lot of it's probably psychological variables, depression, anxiety, a whole range of other things that we can't get a grasp of measuring. So I'd question that we can use AI to predict that someone's going to respond or not to certain treatments. We can give some guidance, but I think that clinical insight probably is important as well.
Thank you. Okay. Well, we'll kind of run out of time now. So I just want to thank our speakers for putting the time to do the presentations. It was really fascinating set of ideas and issues raised, and we're really going strong in Opus in trying to address some of these within the context of the clinical issues that we're looking at. So thank you everybody, and hand over to Cyril.
Thank you, Professor Tony and Maria, for chairing this session. We're going to break out and go into our lunch break, and we'll be back